Good afternoon and welcome to this exciting webinar jointly organized by the European Stroke Organization, the World Stroke Organization, and the American Stroke Association. My name is Guillaume Turc, and I am a stroke neurologist from Paris, France, currently serving as Secretary General of the European Stroke Organization. It is a great honor to co-moderate this session with Luciano Sposato, Professor of Neurology at London Health Science Centre in London, Ontario, Canada. Luciano led the scientific committee of the 2025 World Stroke Congress in Barcelona, which was held from October 22 to 24. Today, four world-renowned experts will provide concise overviews of the key clinical trials presented at the Congress. This conference was a major success, featuring excellent science and outstanding networking opportunities. If you are joining this webinar, it probably means you were unable to attend in person. So to begin, here is a short video of what you missed in Barcelona. We encourage all attendees to engage actively by submitting their questions through the Q&A function. We have disabled the chat, but we will dedicate time after the four presentations to address the most important questions. And so without further ado, let us begin our program. It is my pleasure to introduce our first speaker, Eva Mistry. Dr. Eva Mistry is the current Vice Chair of Research and Division Director of Vascular Neurology at the University of Cincinnati. Please, Eva.
Thank you so much, Guillaume. I will be talking about four trials today. This is a bit of the whirlwind and key highlights of these trials. We'll go really fast. The first one is TRACE-5, which is tenecteplase for basilar occlusion. Catalyst TNK, which was an individual patient data meta-analysis of TNK versus alteplase. Titanic TNK trial of non-large vessel occlusion patients with MRI selection and extended window, and IAT-TOP, which is IA alteplase for vertebrovascular occlusion patients undergoing successful endovascular treatment. The first one is TRACE-5. The objective of the trial was to test the hypothesis that tenecteplase, in addition to thrombectomy, if applicable, administered within 24 hours after symptom onset for stroke, is superior to standard medical treatment. Standard medical treatment was considered alteplase within 4.5 hours of standard care or no lysis, with or without thrombectomy, in patients with acute ischemic stroke due to basilar artery occlusion. This is a phase 3 probe design, which is prospective randomized blinded endpoint adjudication trial in China. Select inclusion-exclusion criteria include adult patients with basilar artery occlusion visible on CTA or MRA at baseline who presented within 24 hours of their symptom onset. Exclusion criteria were posterior circulation aspect of less than 6, significant mass effect, or bilateral extensive ischemia. The arms in this trial, the intervention was considered tenecteplase at 0.25 milligrams per kilograms, max of 25 milligrams administered within 24 hours with or without EVT, and then a TPA within 4.5 hours or no lysis if beyond 4.5 hours with EVT. The results are here. A total of 221 participants were included in the tenecteplase arm, 231 in the control. The primary outcome was MRS less than equal to 1 or return to baseline at 90 days, which was achieved in 37.9% of participants in the tenecteplase arm versus 28.6% in the control group, resulting in an odds ratio of 1.5 towards a better outcome in the tenecteplase arm. Symptomatic ICH rate was not statistically different, 1.8 versus 3%. And here is the shift of the overall MRS down below, standard medical treatment arm in the first bar and the tenecteplase in the second. Overall, more patients in the tenecteplase arm were towards the left of the MRS distribution. The second study is Catalyst TNK. This is an individual patient data meta-analysis of TNK versus alteplase. The objective was to harmonize the data from clinical trials that studied tenecteplase versus alteplase within 4.5 hours of last known well, and to refine the non-inferiority and test superiority of tenecteplase compared to alteplase. Again, as mentioned, this is an individual patient data meta-analysis. The plan was to include these trials listed in this table. Some of the trials or one arm of the TRACE trial did not have the individual patient data yet available and were not included in this interim analysis that was presented at the World Stroke. The results of the meta-analysis, interim analysis are here. A total of 2,186 participants included in alteplase group, 2,177 participants in tenecteplase. MRS 0 to 1 was achieved in 35.7% in alteplase group, 56% in tenecteplase, with an absolute difference of 2.3% favoring tenecteplase group, with a interval of -0.6 to 5.3. The authors had pre-specified two non-inferiority margins at a level of -3% and -1.3%. Both of them, as you can see here, were met. Superiority, however, was not met, with relative risk of 1.04, with an interval of 0.9 to 1.1 and a p-value of 0.1. The third trial I will present is Titanic TNK. The objective of this trial was to evaluate superiority of intravenous tenecteplase for acute ischemic stroke patients without a large vessel occlusion within 4.5 to 9 hours of onset, using MRI imaging to identify favorable tissue window. The design was multi-center randomized open label trial, randomized 1:1 ratio in 20 stroke centers in China. The participants were adult patients, less than 80 years old, acute ischemic stroke presenting within 4.5 to 9 hours, DWI flare mismatch on brain MRI, and a baseline NIH Sure scale of 5 or greater. These are the results of the trial. MRS 0 to 1 was achieved in 46.2% participants in TNK group and 67.9% of participants in the control group. Favoring the control group, of course, the trial was stopped early because of futility of achieving a superiority outcome in tenecteplase by their DSMB group. And the MRS distribution is outlined here, again showing that the control group had overall a better shift in the modified Rankin score at 90 days. The last one that I will present is IAT TOP. The objective of this trial was to evaluate efficacy of IA thrombolysis, intra-arterial thrombolysis with alteplase among patients with basilar or vertebral artery occlusion who underwent successful endovascular treatment. This is also a prospective randomized open label blinded endpoint design, a randomized clinical trial conducted at 31 centers in China. Select inclusion-exclusion criteria were basilar or vertebral artery occlusion without antegrade flow to basilar artery, posterior circulation aspects of 6 to 10, and post-procedural ETICI score greater than or equal to 2B50, which was achieved with no more than 2 thrombectomy passes. The arms in this trial were intra-arterial alteplase at the dose of 0.225 mg per kg infused at 1 milligram per mil over 15 minutes, distal to the origin of the pica, and the second arm, which was the control, was best medical management. In this trial, a total of 125 patients were assigned to the intra-arterial thrombolysis arm and 122 to control. This trial was terminated early due to futility. There was no difference in the primary outcome of MRS 0 to 2, which was achieved in about 42% of patients in the IA thrombolysis arm versus about 48% in the control arm, leading to a relative risk of 0.9 favoring the control arm. No significant difference in mild, moderate, or severe bleeding, suggesting a potential safety. That is all I have. Thank you so much.
Thank you very much, Eva, for this nice overview. And now we will move on to the second speaker, who is also an AHA-ASA representative. It is my pleasure to introduce Professor Bay Leslie Maswi, who serves as chair of the Department of Neurology at the University of Washington. Please, Bay.
Thank you. Thank you. And for those of you who were not able to make the meeting, we were commenting just before we got on what a fantastic time we had in Barcelona, and congratulations to the World Stroke Organization. It's a pleasure to talk about some of the endovascular therapy highlights. And we're going to talk about 3 multi-center randomized controlled trials that were presented at the meeting. The first looked at who's a candidate for thrombectomy, that's the ATLAS trial. Second looked at thrombectomy technique differences, which is Angel Coast. And the third is actually in the hemorrhagic space, looking at embolization of the middle meningeal artery for chronic subdural, that's EMA-CAN. So let's start with ATLAS, which was presented by Amru Siraj on behalf of the investigators, the ATLAS collaboration. ATLAS, think about ATLAS like the ERMES of large core trials. You remember ERMES did individual patient level analysis for patients within 6 hours. ATLAS looks at all the large core studies, and you can see the studies here and their relative contribution to the central pool. It ends up with 944 thrombectomy patients and 942 medically managed patients, and then these 2 groups were compared to understand benefit and to explore subgroups more. The primary outcome was functional. I doubt anyone is surprised that this was a strongly positive analysis for shift analysis, for MRS 0 to 2, for MRS 0 to 3, and interestingly for mortality as well. You can see the grotto bars there. From a safety standpoint, there was a statistically higher rate of symptomatic intracranial hemorrhage and a little bit of a numerically higher rate of neurological worsening, neither of which was enough to offset the benefit of thrombectomy. Every subgroup that was analyzed, remember part of this pooling allows you to look at subgroups more closely. Every analyzed subgroup benefited from endovascular therapy, except, as you see there, patients that came in with the pre-treatment core volume of more than 150 cc's, and those that had an absent mismatch profile. And I'll say a little bit more about that in a second. So in conclusion, ATLAS demonstrates, reconfirms the overwhelming benefit of endovascular therapy in a wide spectrum of patients with large core strokes. Remember, these trials had slightly different criteria for imaging and inclusion and time points and all. And across nearly all subgroups, that benefit was maintained. There are additional analyses pending, and this was not centrally core lab adjudicated. So we should anticipate at the time that this is published that there will be central core lab adjudication. Each trial's core lab's input was combined. Publication, of course, is pending. I look forward to combing through that. But these results confirm the superiority of endovascular therapy and underscore that if we have a patient with a large core infarct, we should be taking them for thrombectomy. So that was exciting. Congratulations to all the investigators. It always takes an army, and I appreciate all that work. Second trial we want to talk about is Angel Coast, and this was presented by Raul Noguera and Dapen Sun. It was really housed at the Beijing Tiantan Hospital in China and looked at contact aspiration versus stent retriever thrombectomy for basilar artery occlusion. And the hypothesis was that because the basilar is a straighter, more vertical vessel, contact aspiration is a better technique for recanalization in that circulation. As you all know, we typically think about those 2 techniques as being relatively equivalent. This was the trial design. Highlight the inclusion criteria with an NIH stroke scale of 10 or more and a PC aspects of 6 or more. These are obviously all basilar patients. And they had 338 cases that were divided into an experimental group and a stent retriever group, which was the control. Operators had to do 3 attempts with the assigned thrombectomy technique, and the contact aspiration catheter was proprietary catheter used in China. Stent retrievers were a range of different devices. I also wanted to highlight that it was predominantly distal basilar occlusions and proximal, mid-basilar slightly less. We think about those mechanisms often as being different, distal as embolic and mid and proximal is more atherosclerotic and thrombotic. The primary outcome of this trial was not functional, it was technical. So the first pass effect, meaning you've accessed the clot and then you have reperfusion of 2CO3, TQ2CO3. And what you see here is a significant difference between the two groups, 43% of the contact aspiration group and 27% of the stent retriever group who achieved that first pass effect. And that held true with the per protocol population too. In this particular analysis, though, that didn't have a functional implication. So patients had similar outcomes regardless of the technique that was applied. In conclusion, it does look like contact aspiration achieves higher rates of first pass effect. This was not significant in terms of patient outcomes, and additional analyses and future larger studies will be needed. But I think it's intriguing that we do see what looks like a signal of difference in technique, and it might indicate that not every patient will benefit from either technique in the same way. So look forward to this entering the press as well. And I want to acknowledge here the 22 active enrolling sites across these 13 provinces in China and congratulate the investigators. And then the final trial is on the hemorrhagic side, embolization of the middle meningeal artery, which has just gained increasing steam for subdural hematomas. It was presented by Jay Shankar from the University of Manitoba, and that's the team that led the trial. And what they did is they looked at patients that had unilateral symptomatic chronic subdurals. This is not acute subdurals, these are chronic patients, and hypothesized that after drainage, embolization of the middle meningeal artery, or EMA, one of my favorite acronyms, was effective and safe, reducing the recurrence risk. Now remember, there are several trials that have already published in this space, and there's still several open questions. This is how the trial was designed. They had 192 patients who were enrolled. They'd already had surgery, and then they were randomized. They either had EMA or no EMA. I highlight here that the EMA was accomplished in a very standardized way. They used liquid embolic, onyx is what they injected here. They had targeted devascularization goals, and it had to happen within 72 hours of the surgery being completed. When they analyzed the results, they were looking at radiographic and symptomatic recurrence, and this trial was strongly positive, as you see here, a 3.5 times decrease in radiographic recurrence. I was quite struck by the almost 50% recurrence rate for the control group, and then a 6.5 decrease in symptomatic recurrence. And there were no adverse events that were attributable to embolization in the studied population. So this trial highlights that as an adjunct to surgical drainage, EMA lowers the odds or the risk of radiographic and symptomatic recurrence. Again, there's a publication pending. 1-year follow-up and registry data are future planned for this group, and this further underscores the role of EMA for chronic subdural hematoma. Remember, this subdural hematoma surgery is said to be the most common neurosurgical procedure by 2030. I think we're building this increasing body of information that we can help augment surgical drainage, maybe prevent it altogether. And I'm going to end on that. These are the teams involved, many recognizable faces there. Congratulations to all these investigators, and thank you.
Thank you very much, Bei, for this nice overview. So we will have time for questions after the remaining 2 presentations. Please do not be shy and use the Q&A feature to send your questions. It is now my pleasure to introduce our third speaker, Dr. Ian McGurgan. He is a vascular neurologist currently working in Switzerland and holds a postdoctoral clinical research fellowship from the University of Oxford. Please.
Thank you very much, Guillaume, and to the organizers. I'll be presenting some of the highlights in the world of secondary prevention from the World Stroke Congress this year. And myself and the organizers have picked out 3 studies from the plenary sessions to present. So we know, despite all of the advances in the last couple of decades in secondary prevention, the residual risk of recurrent stroke is still too high, around 6% after TIA and minor stroke in the first year and up to 10% after intracerebral hemorrhage. And there were a couple of key areas of uncertainty that were addressed at this year's World Stroke Congress. The first is, can we optimize antiplatelet treatment, particularly in the most high-risk groups, notably people with intracranial artery stenosis, so predominantly in Asian populations? The second is, can we start blood pressure treatment in the early phase after TIA and minor stroke? We know that this period is the period of the highest risk. So that was another question addressed. And then the third is, can we intensively and should we intensively reduce blood pressure for long-term secondary prevention after intracerebral hemorrhage? And how might we do this? Is an approach using a combination therapy one that might reduce risk effectively? And these were addressed in the CHANCE-4 trial presented by Dr. Jing and colleagues from China, the COMMIT study, which I presented on behalf of Professor Rothwell in Oxford and my colleagues there. And possibly the highlight from the Congress was the TRIDENT study, the TRIDENT trial presented by Professor Craig Anderson and the George Institute. So I'd like to start with CHANCE-4, which is the latest sequel, so to speak, in the CHANCE series. I struggle to keep up now with all of the CHANCE trials. We know from CHANCE and from POINT and from CHANCE-2 indeed that dual antiplatelet therapy is key for reducing risk after high-risk TIA and minor stroke, and it's really become the standard of care. However, we also know, if we look at some subgroups in these trials, that patients with intracranial artery stenosis, the residual risk still remains high, even with dual antiplatelet therapy. So it's a high-risk group with a high residual risk. Tirofiban is a treatment which has been investigated, an antiplatelet treatment which has been investigated in a number of trials, Rescue BT 1 and 2, and most recently in the ASA IT trial. And then this glycoprotein 2B3A inhibitor has been shown to be effective in terms of clinical outcomes after major ischemic stroke, but it hasn't been investigated in TIA and minor stroke for secondary prevention, notably in this high-risk population with intracranial artery stenosis. So to briefly summarize the CHANCE-4 trial, this included patients with a high-risk TIA, so ABCD score of 6 or more, or minor stroke, with confirmed intracranial artery stenosis. So that's 50% or more on neuroimaging or Doppler, which was judged to be symptomatic, so in the territory of the lesion or the clinical symptoms. Around 4,500 patients were randomized either to placebo group with standard of care or tirofiban infusion, which was given as a bolus and then a 48-hour infusion. The primary outcome was any new ischemic stroke within 90 days, and then they had defined disabling stroke and as a secondary endpoint, as well as bleeding events as a safety endpoint. I think it's important to note in the study that the vast majority were already on dual antiplatelet therapy, so it was a well-treated group in this study. In terms of the result on the primary outcome, there was a fairly substantial residual risk, unfortunately, of recurrent stroke in both groups with no difference. Likewise, for all of the secondary outcomes tested, and also no heterogeneity across subgroups. In terms of safety, there was an equal, fairly low rate of severe bleeding events, which is in line with the existing trials of tirofiban, but an increase in any bleeding on tirofiban, which was also seen in the previous studies. So overall, a negative trial. Next, I'd like to briefly summarize the COMMIT study. The rationale for this study is that, of course, we know in the early phase, in the acute phase after major ischemic stroke, blood pressure lowering treatment is of no benefit or even harmful, but there's uncertainty that remains in TIA and minor stroke. And that's particularly because, as you can see here, we plotted the existing trials of secondary prevention along a curve of residual one-year recurrent risk in our population in Oxford in the UK. And these trials recruited after the acute phase mostly, so after the very high-risk acute phase, sometimes after months or even years after the acute event. And also in the panel on the right, like most randomized trials, they recruited people who were younger than the normal distribution of age of patients with TIA and minor stroke. So because of that, we investigated this question in the context of a population-based study with a sequential comparison of a policy change. And using this population where we included everyone with TIA or minor stroke, it allowed us to really look at safety outcomes in this population, which often isn't generalizable from trials. And you can see with it, we managed to see people much more quickly, so on average within 2 days after these events, and over a third of our participants were 80 years or older, so a real representative cohort of the actual population that we see with TIA and minor stroke. We included over 4,000 participants, and in 2008, there was an introduction of a new policy of more intensive blood pressure management, which came about really due to observations in the population of a high subacute or a residual subacute risk of recurrence despite intensive antithrombotic therapy, lipid-lowering therapy, and even prescription of blood pressure-lowering agents in the acute clinic, which was the intervention in the EXPRESS trial, which was performed in, or the EXPRESS study, which was performed in the same population. The main outcomes of this study were safety outcomes, so it was to ensure that early intensive blood pressure lowering treatment in particular did not increase the risk of stroke or severity of stroke. The policy was to give participants a remote telemetric blood pressure monitor, or at least to offer them one, and medication was prescribed directly to participants or to their pharmacies to rapidly increase blood pressure lowering therapy in the days that follow these events. Temporal trends remain stable in the population between the two policies, which is really important, obviously, in this context to have inference about the results. And we found an impressive increase, despite normal stable baseline blood pressure, an increase in blood pressure lowering medications at follow-up and a big decrease in blood pressure across the whole population level. So that's including people who didn't go on to even have the remote telemetric blood pressure intervention. So a 10 millimeter systolic blood pressure drop. We didn't see any increase in stroke or bleeding risk, rather the inverse, with a 44% reduction in 90-day and 1-year major recurrent stroke risk, and a decrease in disability at first follow-up according to rank and shift. And finally, for the TRIDENT trial, well, we have plenty of evidence on acute phase blood pressure lowering intracerebral hemorrhage, but much less for sustained post-acute blood pressure management, which probably holds the most potential to improve long-term prognosis and recurrence following ICH. So before TRIDENT, we have no dedicated trials addressing this question, at least that looked at clinical outcomes. We know from observational studies, of course, that there's a stronger association between usual blood pressure and ICH than for any other cardiovascular event. And the main prospective randomized data that we have on the effects of blood pressure lowering after ICH come from the PROGRESS trial, where there was a 50% relative risk reduction for the 700 or so patients who had a baseline ICH, which was more than double the reduction in ischemic stroke, despite comparable reductions in blood pressure. So this is an ideal population group to test intensive treatment in. TRIDENT therefore aimed to determine the effects of a more intensive long-term blood pressure lowering regimen with a triple half-dose combination pill of telmisartan, amlodipine, and indapamide versus matching placebo on top of standard care. And the primary outcome was the time to first recurrent stroke. Secondary outcomes included major vascular events, cardiovascular death, and of course, blood pressure control over a mean follow-up of 3 years. They recruited just under 1,700 participants of a mean age of 58, of which 2/3 were recruited from Sri Lanka, but with centers globally. The second biggest recruiting centers were Brazil and Nigeria, from memory. Important to note, there was a 2-week on-treatment run-in period during which around a quarter of patients were excluded, mostly due to a rise in creatinine. The threshold they had defined was a more than 20% rise in creatinine, which I think you could argue, and even the investigators argued, was probably a bit too strict as a criterion to exclude, but that was based on regulatory obligations, but also, of course, due to problems with adherence or intolerance. About 3/4 of the recruited patients had deep bleeds. So in terms of the results, on the top panel on the right, you can see the blood pressure reduction, which was very impressive, a 9 millimeter average reduction, more or less sustained throughout the follow-up period, apart from a little increase at the very end in the treatment group. Adherence to the study medication was very high, 86%, but that needs to be interpreted, of course, in the context of an on-treatment run-in. And then from the primary outcome, there was a 40% reduction in recurrent stroke, which was highly significant. You can see, interestingly, from the hazard curves that they diverged after about 1.5 years, which is similar to what was seen in some of the older trials of blood pressure lowering in secondary prevention. There was no different effect by subgroups investigated. And for one of the secondary outcomes for recurrent ICH, there was an absolutely massive reduction, 60% reduction, which is in keeping with what we know about the biggest effect sizes for bleed reductions. And also really emphasizing how important intensive blood pressure lowering is in this population. In terms of cardiovascular death, there was no increase in the treatment groups, which also serves as a safety signal. Otherwise, in terms of safety, there was no signal for adverse events, falls or syncope or otherwise. There was a decrease in renal function in the treatment group, but again, this was probably just consistent with normal increase in creatinine on blood pressure lowering treatment. But of course, we need to monitor our patients who we start on new blood pressure lowering treatment. So should we change our secondary prevention practice on the basis of the WSC this year? I think we should. For the first question, in high-risk TIA and minor stroke in patients with intracranial artery stenosis, we shouldn't routinely add tirofiban. In patients with TIA and minor stroke who have hypertension, we should start early blood pressure lowering and rapidly intensify. And then for our highest risk patients with intracerebral hemorrhage, we really should be very aggressive in the long-term phase in targeting strict blood pressure control. And based on all of the problems we have in doing this in clinical practice due to therapeutic inertia and otherwise, it seems from Trident that a combination pill might be a good strategy to achieve this. And that's all from me. Thank you very much.
Thank you very much, Ian, for this very clear overview. I can see already that we have lots of questions regarding to this presentation. We will address them at the end of the webinar. And it is now my pleasure to reintroduce my co-moderator, Professor Luciano Sposato, who was the chair of the scientific committee of the conference. Please, Luciano.
Thank you very much, Guillaume, and everyone for the opportunity to present these 3 trials: stable on rhythm control for secondary stroke prevention, PRO-LEVIS for anti-epileptic therapy for the prevention of seizures in patients with ischemic stroke, and focus of using ganglioside GM1 in patients with acute ischemic stroke. So the first trial is stable, in which the investigators from Japan tried catheter ablation for secondary stroke prevention in patients with AFib on edoxaban. So all patients were on edoxaban, and this study was sponsored by Daiichi. So in terms of the rationale, there are still lots of strokes happening despite anticoagulation. These are usually pretty severe and disabling. And on the other hand, rhythm control has shown to reduce stroke risk in patients with atrial fibrillation, but not with an acute ischemic stroke. So the trial included patients with atrial fibrillation with a recent ischemic stroke within 6 months. All these patients were treated with the edoxaban, and they had a baseline modified Rankin scale of 3 or lower. Some patients were excluded if they had contraindications for oral anticoagulation, if they had antiarrhythmic resistant atrial fibrillation, chronic kidney failure, a decreased ejection fraction of the left ventricle, or previous catheter ablation. The treatment arms were usual care with edoxaban or usual care plus ablation, and the primary endpoint was a composite of ischemic stroke recurrence, ischemic stroke or systemic embolism, myocardial infarction, or ischemic events requiring revascularization. The safety endpoint was the presence of periprocedural complications, and the follow-up was 3 years. In total, in the intention to treat population, there were 124 patients treated with edoxaban and only, and 125 with edoxaban plus catheter ablation. There were a few crossovers, as you can see in the slide. And the interesting thing is that most of the patients were males. And this is something that you will see is pretty consistent across most of the trials. So the age was around 71 and 72. In terms of the primary endpoint, it was non-significant. As you can see here, there were 4.9 events per 100 person years in the standard medical therapy, and there was 5.6 in the one with catheter ablation, so no significant differences in the primary endpoints or any of the secondary endpoints. In terms of safety outcomes, there was one case of cardiac tamponade and one case of periprocedural stroke in both in the ablation group. So in conclusion, for the stable study entirely done in Japan, it's a multi-center trial, patients with atrial fibrillation and a recent history of stroke. The addition of catheter ablation did not result in superior or better outcomes than standard medical therapy in terms of recurrent stroke or any of the composite outcomes. In terms of ProLevis, this is a second study done in India. It was the main goal was to test whether levetiracetam could prevent stroke seizures compared to usual care. The rationale was that stroke is a leading cause of acquired epilepsy, and post-stroke seizures usually result in worsened quality of life outcomes and increased costs. The population comprised patients with ischemic stroke, cortical involvement, and less than 14 days since stroke onset. And treatment arms were usual care plus placebo, which was identical to the pill of levetiracetam. Patients received 250 milligrams twice daily for the first week, and then depending on their weight, they received either 500 or 750 milligrams twice daily for 3 months. The primary endpoint was a clinical seizure within 12 months post-stroke, and there were several secondary endpoints, as you can see here in the slide. There were a total of 215 patients in the intention to treat population receiving placebo, and there were 215 receiving levetiracetam. Some patients had to be excluded for several reasons, and the per protocol population included 176 and 167 patients. This was a fairly young population, and again, there was a quite substantial male predominance in the population of the trial. In terms of the primary endpoint, it was non-significant. As you can see, there were 13 events in the usual care plus placebo group, and there were 12 events in the levetiracetam group with no significant differences in the primary endpoint, either for the modified intention to treat population or the per protocol population. There were no differences in any of the secondary endpoints, and in terms of safety endpoints, they were numerically higher in the levetiracetam group, as you can see here as well. So, in conclusion, in the ProLevis trial, in patients with acute ischemic stroke, levetiracetam did not reduce the risk of seizures within 12 months post-stroke. The third study is a FOCUS trial in which investigators from China conducted a multi-center randomized double-blind placebo-controlled trial of ganglioside GM1 for acute ischemic stroke. So the rationale is that GM1 seems to be a neuroprotective agent. A few decades ago, there were a few RCTs showing that GM1 was associated with better outcomes, but these trials were conducted when EVT was not available, and T and K or TPA were not massively used. So the population included ischemic stroke patients with an ICA occlusion and a modified ranking scale of 1 or less, with an onset within 24 hours before screening and an NIHSS of 7 to 24. Importantly, patients with undergoing EVT were excluded. In terms of treatment arms, patients received placebo for 12 to 14 days after ischemic stroke, and the treatment arm received GM1 for the same period. The primary endpoint was a modified ranking scale of 2 or less at 90 days, and there were several other secondary endpoints with a modified ranking scale at 14, 30, and 90 days, and other endpoints as well. The follow-up time was up to 90 days. There were a total of 503 patients included in the placebo group and 516 in the GM1 group. There were some major protocol deviations, which I'm not fully aware of the details. And in total, the per protocol population included patients with placebo and for a total of 420, and per protocol for the GM1, 431. Again, a fairly young population of stroke patients with a substantial predominance of male patients. So in terms of the primary endpoint, there was significant differences in terms of the primary endpoint of modified ranking scale of 2 or less at day 90, with 57.5% of the population in the placebo group and 67.6% in the GM1 group, with a rate difference of 10.16 and on odds ratio of 1.56. The only secondary endpoint that was significant at 90 days was a modified ranking scale with a rate difference of 6.63. There were no significant differences in safety endpoints or any other secondary endpoints. So in terms of conclusions, GM1 significantly improved 90-day functional outcomes in acute ischemic stroke patients with a favorable, or I would say safe profile overall. And I think this is the end of my slides. And so I would like to invite everyone to join the panel again, all the speakers, and we're going to move forward with the first questions. I know, Guillaume, if you want to take the first one. And
yeah, absolutely. So this first one might be for Bei. This is actually a double question. Do you think a trial in very large cohorts, more than 150 males, is in patients without mismatch, is still warranted?
So, I made the point when we talked about the ATLAS results that it was not centrally adjudicated from an imaging standpoint. Each trial had its own central adjudication, but this individual patient data meta-analysis was not centrally adjudicated. And remember, these are trials that had CT or MRI, they had perfusion or non-perfusion, they had early and late. And so there's a lot of variability there. And I don't think we should hang too much on that number yet. Let's wait until we see the centrally adjudicated data, and then we can decide what follows from it. I do think the message, though, is that if you have an occlusion, you should probably get thrombectomy. Remember, above 150 cc's in the existing data, there wasn't harm. It's just that there was no benefit. And so I think there's always this tension between how selective do we go? And that ties into the second question that I see there, which is about perfusion imaging. I think there are a range of opinions about the role of perfusion imaging now that we have large cohort data. I'm happy to share my opinion. My opinion is that if large cohort patients benefit, then there's really much less reason to do perfusion imaging. You do the simplest, quickest imaging possible to make a decision that this is someone who should go for thrombectomy. And the real question these days is there a large vessel occlusion within 24 hours? Use aspect score, CTA, and make a decision from that. So that's sort of the way I frame it. I see, Luciana, you have your hand up. You want to add to that?
Yeah, I wanted to provide an alternative perspective because, for example, we are a regional stroke center serving 13 hospitals, and sometimes we have limited resources, right? So when you have to decide, when you have two patients at the same time and you have to decide which patient you will bring to your hospital, do you still think that more than 150 milliliters justifies the use of resources when the outcomes may not be as strong as for others or smaller strokes? That just to, yeah.
Yeah, no, I think that's a very important question because resource is one of the considerations with the large core population. There are also all the modifiers, right? Think about a patient with 120 cc infarct who's 19 versus a patient with the same infarct who's 80, right? And so I think every individual environment will have some specific considerations. Ava, you have a comment to add to that too.
I have a short comment to add. The push and pull is resource versus access here, right? And I do think in the ideal world, a CT-based selection of how dark an area is and how viable that tissue is. And I know there are a few groups working on that to remove, because CTP itself is you could consider a resource intense, procedure. It's not readily available in many parts of the world. And if we could kind of gather, hopefully from what Wei was saying, the central adjudication of or pooling of the images, and if we can gather CT-based variables to select patients so that we're not treating a lot of patients who are not going to benefit, but still allow a lot of these patients to be treated based on the minimum amount of imaging possible, that would be the ideal situation in my opinion.
Excellent. So we can move to the next question. Does the etiology of basilar artery occlusion, for example, embolic versus atherosclerotic, influence the choice of the method for the mechanical thrombectomy?
Yeah, this is a reference to the Angel Coast study. And you remember in the Angel Coast study, you had distal, mid, and proximal basilar occlusions. I didn't show some of the subgroup work there because there wasn't time. But in the subgroup analysis, patients that had ICAD as the cause of their stroke did not demonstrate a difference in first pass effect between contact aspiration and stent retriever. Now, again, it's a small study. And so it's not clear how a diagnosis of ICAD was made. That's something that we'll look for when the publication comes out. I personally always struggle with that. The level of occlusion gives you clues, right? But how do you know there's an underlying lesion pre-procedure? And so I think that's an open question still to be explored.
Thank you very much. Now we have a question for Ayan. So given the results of Commit and Trident, would you recommend the triple therapy polypill immediately after a TIA or monostroke as best option?
Yeah, it's a very good question. I think there's some nuances there. The first thing is that Trident had a run-in period and they recruited after the acute phase. So we're dealing with two different time points between Commit and Trident in that sense. Another thing that I didn't go into detail about, but the polypill approach in secondary prevention works really well, particularly in low-income settings. In the Trident trial, that was essentially the case where the trial was performed, and it's a great option. And we know already from primary prevention that combining treatments in smaller doses, particularly for hypertension, is probably more effective. Even the results of some of the main trials like Progress showed that the combination therapy was probably better than individual therapy. But could we just prescribe, do we have sufficient evidence at the moment to just prescribe a polypill, including lipid-lowering therapy, antiplatelet therapy, dual antiplatelet therapy, and blood pressure-lowering therapy? I don't think we have sufficient evidence. I don't think we can conclude from these studies that we're there yet. In Trident, obviously, as I said, we're after the acute phase, so people could have had some adjustment of blood pressure medication in the high-risk acute phase already. In Commit, we did more than just prescribe an initial combination regimen for everybody, although we did try to follow the Progress-style regimen with perindopril and indapamide for many patients. In practice, what really made the difference, and we did also some controls looking at the group who actually had the intervention, a kind of per protocol analysis versus those who didn't. What really made the difference was the rapid intensification. So not just starting treatment, but rapidly intensifying afterwards. Often what we give in the first instance isn't sufficient. And that often included introduction of more than 2 agents, increasing doses. So I think to use a blanket polypill approach on a population-based level, global health perspective, I think it would work, but I think we can do better. And we know the residual risk is too high. So my answer would be we're probably not there yet to recommend it.
Thank you, Ayan. There are a couple more questions about the Commit trial, and I think I'm going to ask both together. So the first one is there any interaction analysis showing harm in patients with ICAD? And the second one is whether patients with significant carotid stenosis were excluded from the trial.
Yeah, those are good questions too, which I didn't have time to address. So I'll start with extracranial and then I'll talk a bit about intracranial disease. For extracranial disease, we know from observational studies that that we can be aggressive with blood pressure lowering as long as there isn't bilateral significant stenosis. So unilateral disease is usually not something of risk. So in that perspective, we're fairly free to treat aggressively. In the Commit study, we were obviously worried about this question. We had the same reflection and we were worried about safety. Everyone in the population had vascular imaging. So that is a bit of a caveat to the result, that these are people in whom we screened who had vessel imaging before we treated. And for people who did have bilateral significant stenosis, or multifocal flow-limiting intracranial stenosis, we adopted a less aggressive target. So we usually targeted 140/90 rather than less than 130/80. We didn't see any harm, and we did subgroup analysis looking at people with and without significant flow-restricting intracranial stenosis, and we didn't find any harm signal. But then again, we were a bit less aggressive in these patients. So I think it is an important caveat or modifier to the application of these results.
Thank you, Ian. Two questions for Luciano regarding GM1. So what do you think will be the next steps for this drug? And then do you have any information on why EVT patients were excluded?
No, well, regarding the first question, I think it would be interesting to conduct the same trial in a different population to see if it works and if the mechanisms really apply to a non-Chinese population as usual. And then in terms of why EVT patients were excluded, I don't know. Honestly, it's a large trial. The patients had occlusion of the ICA. I guess I'm not sure if it was proximal or distal. We don't have data on that. But I don't have a clear reason why they were excluded.
Thank you. Eva?
It's a speculative reason, maybe for exclusion. We know that finding incremental effect, either for neuroprotection or lytic, on top of endovascular treatment is really, really hard. And I suspect that that is probably why they were excluded. It's nice to see that there's an option for patients with no immediate access to endovascular treatment for potential neuroprotection, but that's my speculation for.
And go ahead.
It was just to say, I think the context as well was that they did it in a setting where it wasn't available in many centers. It's something they mentioned during the presentation. So I think it was another reason why they just decided to exclude, because in many centers they recruited, they didn't have the possibility, especially out of hours, to intervene.
Thank you. Okay, and so I think we have a question here for Eva. Does the Houndfield unit in the infarct areas affect EVT decision in large core infarct, or it's for Bay? I guess both commented on the same.
My answer is we don't know yet. I hope that we will know soon. I think that would be ideal in either Houndfield unit or a proxy measure of salvageable tissue, truly salvageable versus non-salvageable tissue in terms of net water uptake. I know lots of groups are working on identifying CT-based parameters to identify ideal patients to treat, but I don't think we have a firm answer yet.
Thank you. So another question for Ian, for early intensive blood pressure lowering after TIA or high risk minus stroke. What are the initial BP targets, and within what time frame should we achieve normal tension?
Mm-hmm. Well, I mean, that's a question that hasn't been addressed in trials. It's we know there are plenty of trials on more intensive versus less intensive blood pressure lowering and secondary prevention. Many of which I've shown, SBS3 and others, which recruited people late, so after the acute phase, which is one of the reasons we tried to address this in the commit study. For the question about what target to treat, well, the target in secondary prevention guidelines at the moment is less than 130/80, which I think is reasonable. It appears like there's a mostly linear association, but some studies show a J-shaped relationship between blood pressure and risk, so perhaps we have to be cautious in certain groups. And in terms of the timing, I think that from the commit study results, we have sufficient evidence to show that it's safe, which is also harder to generalize from randomized trials. And it's safe in the early phase. As I showed in some of the slides, we recruited people and treated people much earlier. Treatment was given in the acute clinic, or prescription was given immediately. It was rapidly intensified on the basis of home monitoring within hours after the event, or at least within days, and we've shown that it was safe. So I think I don't see any reason to have various targets at various time points based on the evidence that exists at the moment. And I think what we can do now, probably now that we know it's safe from commit, we can really extrapolate the results of the existing trials of secondary prevention blood pressure lowering for ischemic stroke and TIA, and extrapolate those results to the acute phase after TIA and minor stroke. So I don't think we have to have a different target in mind in the early phase. Of course, one last point is that there is often spontaneous decrease and resolution of blood pressure after TIA and minor stroke and after major stroke. We have this acute phase hypertensive response with spontaneous resolution. And that was one of the reasons, and also because of the possibility of harm, that we decided to give everyone a remote telemetric blood pressure monitor. We had the exact same concerns as the people on this chat have raised. And in the end, there was a very, very small number of people, around only 3 to 4%, in whom we actually had to reduce treatment because of hypotension on home readings. So also that worry about, are we over-treating in the acute phase due to the acute hypertensive response, it really didn't pan out in practice.
Could I just make a comment on that? One of the things that struck me during the Trident presentation was exactly that we have this concern that there's going to be harm, and this is a poly pill that everyone got, small doses of different blood pressure medications, and it seemed to be very well tolerated. And I know there's a camp that feels like in general, as a community, we have not been aggressive enough with blood pressure lowering. It's sort of the vaccine for vascular disease prevention is how it's been described. And so, I just wanted you could reflect on that. Do you feel like we really can be more aggressive in the way we think about this? It sounds like you do from your previous comments.
Yeah, I do. I think we're not aggressive enough. So I think we need to be thinking about treatment early and immediately, and treating more aggressively, particularly after Trident in the intracerebral hemorrhage group. I don't think we were surprised. I don't think anyone was surprised by the results. It was a fantastic trial, and it needed to be done because we didn't have the response, particularly as you mentioned, Bey, about safety. We didn't know whether it would be safe to do that in the long term in these patients after intracerebral hemorrhage. Would it increase the risk of recurrence? Would it increase the risk of stroke, paradoxically? And in fact, there was no safety signal for cardiovascular death, virtually no safety signal for dizziness, fall, syncope, other hospitalizations in Trident. And the only real safety signal that came out was an increase a decrease in renal function, which to a degree is probably just an increase in creatinine, as I mentioned, that is expected in these patients. So we do need to monitor, of course. But I think the real take-home message from these studies is the safety point of view. I think we can treat knowing that these treatments are safe for long-term secondary prevention, and we can be aggressive with blood pressure lowering, just like we are with antiplatelet therapy. I don't think anyone hesitates anymore to treat aggressively with dual antiplatelet therapy, apart from in very select groups. We tend to roll that out across the board. We treat all of our high-risk TIA and minor stroke patients, anyone who's not thrombolized effectively, with dual antiplatelet therapy now. And I think we need to have the same approach for blood pressure lowering as we also do for lipid lowering. I think that's something now people are much more willing to treat with high doses and early on.
Excellent. Thank you, Ian. There's a question here for the panel. Are there any plans on stratifying the effects of theta EVT in patients who are fast progressors or slow progressors? Bey, are you aware of any sub-analysis or?
I'm looking at the question in what context specifically?
I think it's vascular artery occlusion, I guess. Patients who are fast progressors or low progressors.
I'm not aware of any specifics on that. As I say, with many of these trials, we're waiting for the publication, so we'll be able to comb through things in a bit more detail when we have it.
I think this is related to large core MCA infarct, and it is very likely that there will be an Atlas sub-analysis on this, although it might not be the top priority for the researchers at the moment.
We know from non-large core data that there is heterogeneity in treatment effect according to CTP-based evaluation of fast versus slow progression. I wouldn't be surprised if it panned out, but I don't know that it would negate the treatment effect necessarily.
Thank you. So maybe one last question for Luciano. Most patients in AF trials are men, but we know that AF is actually more common in women. So how do you explain this paradox?
Yeah, I think it's more social reason. Women live longer. By the time they develop AF and strokes, they have lost their husband. It's more challenging for them to be part of a clinical trial with fixed dates of follow-up. I don't know. It's a historical problem that despite trials having tried to address it and improve randomization and using several techniques, there has been no significant success. So I think it's a pending item that we need to address in future trials.
Thank you very much. So I think we've spent 1 hour together. It was absolutely wonderful. So we would like to thank all panelists, and I would like to thank also very much my co-moderator, Luciano. And we hope to see you soon at the next conferences. I think the next conference will be in New Orleans. This will be the International Stroke Conference in February. The registration is now open, and then we will have the European Stroke Organization conference in May in Maastricht, the Netherlands. Registration is also now open. And the next World Stroke Congress will be held in Korea, in Seoul, in October 2026. And you will have more information on the website. So thank you very much for attending, and we hope to see you soon at another webinar.